Hi, everyone. Thank you for joining. We're going to wait just a couple of moments for people to join and get on Zoom. All right, I'm going to go ahead and get started in the interest of time. Thanks, everyone, for your patience. Starting just a couple minutes late, apologies. Welcome to the National Center for Healthcare Leadership's Coffee Chat, everyone. My name is Jarrett Fowler, and I'm the Senior Director of Strategic and International Initiatives here at the National Center for Healthcare Leadership, or NCHL. And I'm pleased to be serving as the moderator for today's Coffee Chat, which will focus on assuring access to healthcare for the LGBTQ+ community. A few housekeeping items. We're using Zoom's closed captioning option. So for those of you who may wish to enable your own closed captioning, you can do so at the bottom of your Zoom window. At the end of the session, there will be a very short 3-question evaluation. We'd appreciate your feedback and input on future coffee chat discussions there. The session is also being recorded, and it will be made publicly available on NCHL's YouTube channel. I'd like to invite everyone to learn more about NCHL's work, our premier membership programs, as well as our upcoming 2022 All-Member Conference that's taking place this November by visiting us on our website at nchl.org. I'm really excited to introduce our panelists for today's discussion. First, we have Dr. Sharita Golden, who is the Vice President and Chief Diversity Officer and Professor at Johns Hopkins Medicine. And we're also joined by Paula Nira, who's the Program Director for LGBTQ Equity and Education at Johns Hopkins Medicine. Johns Hopkins Medicine is a program member of the Leadership Excellence Networks, or LENS program, here at NCHL. So in terms of what we're going to be focusing on today, I'm going to be moderating, and one of the things that we wanted to hear about was how our panelists and their organization is working to provide accessible, equitable, and inclusive healthcare for LGBTQ+ patients and employees, which I know is a top priority for many healthcare organizations right now, given the unprecedented recent surge in state legislation designed to create barriers to completely prevent vulnerable populations' access to care. So to start off, I'd like to have our panelists tell us a little bit about themselves. So Dr. Golden, do you want to start us off?
Yes, so thanks for having us. And as Jarrett mentioned, I'm Vice President and Chief Diversity Officer for Johns Hopkins Medicine, and in that role, oversee biomedical workforce diversity for our School of Medicine and our Johns Hopkins Health System, as well as health equity operational strategy for our health system. And just for context, a lot of times when you think of Johns Hopkins, you primarily think of the Baltimore-based hospital, which is also where our School of Medicine is, but we actually have campuses in the DC region as well, what we call the National Capital Region, so Howard County, Montgomery County, Washington, DC. We have 3 hospitals there. We have 2 hospitals in Baltimore. One is Johns Hopkins Hospital, the other is Johns Hopkins Bayview Medical Center. And then we also have an academic pediatric hospital in St. Petersburg, Florida. So just to give you a context, as well as a large ambulatory practice, as well as an insurance arm. So just a broad organization. So as we think about diversity and inclusion in our office, of course, diversity and inclusion for the LGBTQ+ community from a healthcare perspective, as well as an employee perspective, is one of our strategic initiatives.
Thank you so much, Dr. Golden. And Paula.
Hi, folks. I'm Paula Nira. My pronouns are she and her. And this gives me the opportunity to really give a shout out to Dr. Golden's leadership, because the role that I have is a brand new, newly created role in the Office of Diversity, Inclusion, and Health Equity. And I'm moving into this role after having been the clinical program director of our Center for Transgender Health, which we established in 2017. And both of those situations for me reflect where Johns Hopkins Medicine is going. And it's one of the things that everyone has to realize is that the pace of change is never going to be fast enough. Because of the historic structural problems, the cis heteronormativity, the automatic assumption that everybody is straight, everybody is cisgender, was cooked into the system. None of our systems really, thought of how do I be inclusive of LGBTQ plus people. So now that we recognize the errors, how do you go about changing systems? How do you go about addressing the known health disparities, the health equity? How do you build into the system change? And having been involved in changing the US military and ending the don't ask, don't tell policy and changing the regulations on transgender service, I'm aware of how long it takes big institutions to really be able to make change and then enculturate the change. Kind of excited. One of the things we've been working on is things like updating our ID badge policy to allow our faculty, staff, students, vendors, anyone that's part of our community to be able to use their chosen name on their ID badge, so they can bring their more authentic self to work. Working on across our enterprise. And when I say our enterprise, that means our university and our health system, and our School of Medicine is the overlap between those two. Working to expand our coverage of gender affirming care for our employees and their dependents. So it's an exciting time at the same time that, yes, we're dealing with an environment where there's been over 300 anti-LGBTQ bills introduced in the United States. About 140 of them have targeted transgender kids. And it's purely for partisan political reasons. We know it's not grounded in science.
Yeah, thank you so much, Paul, for pointing that out. So my first question kind of for our panelists is about this. So as Paula mentioned, there is a wave, surge, tsunami of anti-LGBTQ plus rhetoric and legislation sweeping over the United States. And as Paula mentioned, we're seeing numerous states passing increasingly extreme discriminatory laws that are specifically designed to block the provision of gender affirming care to transgender youth, for example. One example would be Alabama recently passed the United States' first law that imposes criminal penalties on providers of age-appropriate, medically necessary, gender-affirming care for transgender youth. And in Florida, the state's health department recently released public health guidance that was filled with misinformation that attacks established standards of age-appropriate, medically necessary, gender-affirming care for transgender youth. My question for our panelists is, so given that Hopkins operates healthcare facilities across multiple states, I'm wondering if Dr. Golden and Paul, if you could talk about your approach to maintaining access to care and continuity of care for both the transgender and broader LGBTQ plus populations that your system serves, including for employees.
I think one of the things from a patient standpoint, and also from an employee standpoint, it's interesting because sometimes we talk about patients and employees, and sometimes we forget that sometimes our employees are also our patients. So there's quite a bit of overlap as we think about that. But I think part of it first is we made a very clear statement with establishing the Center for Transgender Health in 2017 that Paula spoke of, that we were going to support access to care for our transgender community. We have certain providers in our system, primary care physicians, who have actually devoted their clinical practice to the care of the LGBTQ plus community and addressing those specific needs. We'd like to have more of them, but but recognizing that this is like a clinical niche area that's important. And even along the lines of things like making sure the clinical intake forms are inclusive. So, it was brought to our attention in one of our pediatric clinicals clinics that it said mother and father. So just saying like parent, for example, or pregnant person. And so going through all of those policies, of course, that one form came up, and then Paula and I were like, okay, how many more forms do we have? So, this summer, one of the things we'll be doing is going through and looking at forms, because something as simple as a form, for example, can create the environment. So for our hospitals that are located in the Maryland and DC area, that we're not in a state where, fortunately, those kind of oppressive like sort of laws are being passed, but we do have our children's hospital in Florida, and our clinicians down there are actually seeing a lot more suicide attempts, self-harming among children who are a member of the LGBTQ plus community, which is very, challenging to them. So we have ensured that those children know that that's still a safe place for them, in a safe space. But as you can imagine, that is very, very, very challenging. So, and even we recently developed through a 6-month process with stakeholders across the organization an equity statement. And, we sort of have made our equity statement such that it can not only be placed in our Maryland hospitals, but in our Florida hospitals to make it clear where we stand, but without, sort of putting us in harm's way. It is a very, very tricky balance, I would say. I don't know, Paula, if you want to speak to some of the other things we've been doing around some of our healthcare policy and other things.
Yeah, I think and speaking of healthcare policy, and again, it's because we're a health system that spans different states, the approach is a little bit different depending on the political environment. And so as an example, in Maryland, we did provide written and in-person testimony in support of an expansion of the Maryland Medicaid coverage for gender affirming care. Now, that particular bill did not pass both houses, so it'll be reintroduced in the next legislative cycle. And Maryland, like many states, doesn't have a year-round legislature. We have a 90-day legislative session. So that demonstrates that the health system, is engaging in all the realms, trying to reduce those barriers to care. Internal, to interacting with our patients is, as Dr. Golden mentioned, we're very clear is that what we do is grounded in science and best practices and evidence-based medicine, in all the realms where Johns Hopkins practices: research, education, patient care. And that's not going to change. And when we look at the political environment, as I mentioned previously, is that these bills are not grounded in science. In fact, they're the absolute rejection of what the evidence is, again, to push a political agenda and a particular worldview. And one of the nice things about besides being a nurse, I'm also a lawyer. So I have an understanding of where this sits in that legal legislative process, because those bills that you mentioned, like in Alabama, all of these laws that have been enacted, and about 8 states have actually enacted the legislation, they're immediately being challenged in the court. And then what you're seeing is they're being enjoined, which means at some level in the court at some period of time, it's on the books, but it can't be enforced as the legal process plays out.
Yeah, we had probably, and you may be able to speak to this. I know of one example. We had a question about, and I saw in the chat, we often hear of anti-LGBTQ legislation versus anti-trans or gender affirming care. Can you correct my assumption? Are there anti-LGBT healthcare legislation or pieces of legislation out there right now that aren't necessarily focusing on the transgender people?
Well, I guess one of the things I was saying, this may be a little bit of semantics, is I'm not going to separate out LGBT from T, because that's, it's the attacks on sexual and gender minorities are attacks on sexual and gender minorities.
Right.
Is, specifically the issues that get to attacking the broader community. So, and if you specifically want to talk about sexual orientation, is there are bills that would not recognize discrimination. Mississippi has a bill that allows, if someone has a religious belief or claims a religious belief, that they can deny care to someone on the basis of their sexual orientation or gender identity.
Mm-hmm.
Some of the bills that are passed are religious liberty bills, or being called religious liberty bills, and I'd be using the air quotes, is that would again allow this argument of, because I have a deeply held religious objection to gay folks, I don't have to provide them care. Mm-hmm. So that's the type of barriers to care that you're seeing. The ability to discriminate with government blessing.
Right. And then, I mean, if thinking beyond healthcare, I mean, if you look at what happened in Florida with the curriculum bill that was
Mhm.
introduced about not being able, teachers can't discuss their sexuality for, I think it's up to a certain age when in the classroom. And we're seeing duplicates of this happen all over the country. So that's not necessarily specific to healthcare, but it
Well,
is related.
But it does have implications. It
It does,
becomes
yeah.
a
Mhm.
healthcare scenario because it's
Right.
very interesting for us in healthcare. I was at the Chief Diversity Officer Forum a couple of weeks ago with chief diversity officers across a variety of industries. So there was a small group of us in life sciences and healthcare. And it was very interesting because for many industries, like, well, our industry is flying people around on planes or selling beer. And, so they have to sort of play to both sides. But for us with healthcare, we have a few more liberties because everything ultimately comes back to health. So by,
Mhm.
saying, okay, well, the kids can't, reveal maybe the uncertainty they're having around sexual orientation to their school teacher means they're holding this in. And those are the kids that we may end up seeing at our children's hospital who are now,
Right.
suicidal
Right, exactly.
or something
Mhm.
like that. So in some senses, a lot of things that happen in policy and legislation do ultimately impact health.
Mhm.
And even I'll point out until fairly recently, in the DSM, the psychiatric diagnostic manual, like sexual orientation that was other than straight was considered like pathology. So then
Right.
that went down a
Yeah,
totally
let's change
different
that frame of
route
reference.
of healthcare, right? So as we think about it, I think to Paula's point, and interesting from my lived experience as an African American, woman, it's like things that get like laced in policy, then like spread to other groups, and so then it becomes like a broader issue. So I think Paula is right in that. I mean, yes, a lot of what's the legislation that's coming out is specific around the transgender community, but it's sort of laced with these other elements too. So it's really challenging to just
Yeah.
distinguish them.
Dr. Wilson, I really appreciate you bringing up the intersectionality component of it. I think that's important. So my next question, it is a good segue, I think. So I'd like to understand a bit how Hopkins, or how and if Hopkins DE&I team engages with Johns Hopkins Medicine's Government Affairs Department on these issues, and what does that intersection look like, and maybe in the past and perhaps going forward?
Yeah, I mean, we collaborate very closely with our government and community affairs. Our government affairs really, we have like a local and state affairs team, and then there's also a federal affairs team. We have interacted primarily, I would say, in the last 2 or 3 years with the state affairs team. And so when there are issues that are specific that are impacting or contributing to health inequities, regardless of the population, we are very fortunate in our Maryland legislature, in both the House and the Senate, that we have representatives who are committed to addressing the issues of health inequities. And many of them were re-energized around the COVID-19 pandemic. So, in the 2021 session in Maryland, there were 5 pieces of health disparities legislation that were passed that we either, testified in support of orally and provided written testimony. So for example, one of those was establishment of a statewide health equity commission. One was requiring unconscious bias training for licensed providers for their license renewals. So, that's addressing all types of bias. For example, and then Paula mentioned there was a Trans Maryland healthcare bill that Paula testified oral testimony and provided written testimony on behalf of Johns Hopkins Medicine. And even though that didn't pass one of our houses, we will raise that again. So any issue around inequity, whether it's the health of our LGBT community, our minoritized communities, our disability community, veterans, any of those groups, we play a very active role with our government and community affairs.
Very, very, very interesting. Paul, do you have anything to add?
Yeah, I would think, for anybody's health system is that to ensure that liaison with their, whatever their equivalent is of our government affairs offices. We have a good working relationship, and it really does stress the intersectionality because, all of the various bills impact on health, and it's not just health of one community, it's everybody.
Mhm. Mhm. Yes,
Mhm.
absolutely.
Yeah. So my last question, I think, and this is maybe more of an open-ended one. So those listening in the audience, so they may be working in healthcare systems located in states where there's pending legislation designed to erect some of these new barriers to care to some of these communities that we've been discussing. And I'd like to know from both of you, what questions would you advise your colleagues at other institutions to be asking internally? And do you have any other advice for them?
I would say, I mean, Paula raised this, is, if you're in a healthcare organization that does have, sort of like a local or state affairs team that follows, the policies and the legislation that are impacting the health of the community, I would bring those concerns to them. And one of the things that the advantages we have as clinicians or those in the healthcare system is that we can provide that subject matter expertise and the evidence base to, either support or refute legislation that may positively or negatively, impact the health of our community. So I think that, one of the things I realized is, as a clinician, that that my voice actually mattered. So if you're in an environment where there's not a state affairs team, like you're in a smaller private practice or something, I was testifying on behalf of Johns Hopkins Medicine alongside Marylanders who lived in a particular district who had the same passion around the issue of addressing health inequity. So, I would just encourage you to, write to your legislators as well. I mean, they are supposed to be representing us. And so we need to really advocate for, the communities that we are serving. And, one of the things Paula knows I often say to my team is like, we're intersections, we're not just one thing, right? So all of these things ultimately, impact our health. So even though, I'm straight as a Black woman, I understand what that discrimination is like and understand the experiences that our LGBTQ community are having in healthcare and even in their work environment. So, I think like that joint advocacy is really important.
Mm-hmm. Paula?
Yeah, I guess the thing that I'd add is that as hard as this is to do, you've got to put the emotion aside and really look at it in a strategic way. You have to engage your legislator, but in these actions, the legislature, some of these legislators simply do not care. They don't care what the evidence is. And you need to be able to assess that very quickly and then be able to provide, as Dr. Golden said, we're the subject matter experts. Our job is to keep telling people what the facts are, what the evidence are, what the limits of what we know are, and being absolutely honest about things, and get that information out to that movable electorate. And also be an internal advocate to get the health system that you work for to use its influence to take a stand for what is right.
Yeah, totally.
And at the same time, take time to do self-care.
Mm-hmm.
Obviously, what we do is very, very emotionally draining.
Mm-hmm.
It's very psychologically draining. And the reality is that the attacks we're seeing in states through the legislature on impacting people's health are not going away tomorrow or this legislative session.